Hello, greeting from Dr. Denny. I am a pathologist. I am from Faculty of Medicine and Health Sciences, University Malaysia Sabah. Here I like to discuss about the renal cell carcinoma. Renal cell carcinoma is 15% of newly diagnosed cancer in the United States. It is 85% of renal cancer in adults. It occurs mostly in older individuals, usually in their 6th and 7th decade of life. Male-female ratio is 2:1. There are some risk factors concerned with the renal cell carcinoma. Tobacco is the most significant risk factor. Cigarette smokers have double the incidence. Pipe and cigarette smokers are also more susceptible. Person with obesity, hypertension, and opposed insulin therapy. Person with exposure to the asbestos, petroleum products, heavy metals are the risk person. An increased risk in patients with end-stage renal disease, chronic kidney disease, acquired cystic disease, and tuberous sclerosis. Most renal cancer is sporadic, but unusual forms of autosomal dominant family cancer occur, usually in younger individuals. There are familial variants. These have been instructive in renal carcinogenesis. These are von Hippel-Lindau syndrome, hereditary leiomyomatosis and renal cell cancer syndrome, hereditary papillary carcinoma, Bart-Hopdorf syndrome. Now we focus on the classification of renal cell carcinoma. Number 1 is the clear cell carcinoma. It is the most common type. 70 to 80% of renal cell cancer. They may be familial, but 95% are sporadic. In 98% of these tumors, whether familial, sporadic, or associated with VHL syndrome, there is a loss of sequence on the short arm of the chromosome 3. The deletion region harbors the VHL gene. The second non-deleted allele of VHL gene shows somatic mutations or hypermethylation-induced inactivation. VHL gene acts as a tumor suppressor gene in both sporadic and familial cancers. This is a broad picture of the clear cell carcinoma. Clear cell carcinoma arises from proximal tubular epithelium, usually solitary and unilateral lesion. These bright yellow, gray-white spherical masses of variable size, the yellow color is the consequence of prominent lipid accumulation in tumor cells. Commonly, there are large areas of gray-white necrosis, foci or hemorrhage, and margins are usually sharply defined and confined within the renal capsule. This is the microscopic feature. The growth pattern varies from solid to trabecular or tubular. Tumor cells have rounded polygonal shape, abundant clear or granular cytoplasm, which contain glycogen and lipids. And the second pattern is the papillary carcinoma. It is about 10 to 15% of renal cancers, characterized by papillary growth pattern. It occurs both in familial and sporadic form. The most common cytogenetic abnormalities are trisomy 7 and 17 and loss of Y in the male patients in sporadic form, trisomy 7 in the familial form. Morphologically, these tumors arise from distal convoluted tubules. They can be multifocal and bilateral. Typically hemorrhagic and cystic, especially when the tumor mass is large. This is the microscopic features. It composed of cuboidal cells arranged in papillary pattern. Interstitial foam cells are common, and psammoma bodies may be present. The stroma is scanty but highly vascularized. This is the chromophore renal cell carcinoma. It is the 5% of renal cell cancer. On cytogenetic examination, these tumors show multiple chromosome losses, extreme hypodiploidy. They are thought to grow from intercollected cells of the collecting ducts, but they have excellent prognosis compared to that of the clear cell and papillary cancer. Histologically, pale eosinophilic cell, often with perinuclear halo. These are the perinuclear halo, enriched in the solid sheets, with concentrating of the largest cell around the lever cells. This is the collecting duct carcinoma. Approximately 1% or less than 1% of renal epithelial neoplasia. It arises from collecting duct cells in the renal medulla. There are several chromosomal losses and deletion. Histologically, malignant cells forming glands and match with the prominent fibrotic stroma. These are the glands and the stroma, fibrotic stroma, typically medullary location. These irregular glands line by highly atypical epithelia. These are lined by atypical epithelia with the Hoffmann pattern. So, regarding the spread of the disease, they are local spread and the distant spread. Via the local spread, tumor enlarge and they may bulge into the renal calyx and the pelvis. Eventually, tumor must fungate through the wall of the collecting system and to extend into the ureter. Via the distant spread, the hematogenous spread, one of the striking characteristics is tendency to invade the renal vein. It extends up to the inferior vena cava as far as the right side of the heart. Lung, bones, regional lymph nodes, liver, adrenal gland, brain can be metastasized. So here I discussed shortly about the clinical features and the average 5-year survival rate. Clinical features are, patient present with a costovertebral pain and palpable mass and hematuria. Most reliable clue is the hematuria. The hematuria character is the intermittent and maybe macroscopic. The tumor remains silent until it attains the large size more than 10 cm. Also, it is associated with the constitutional symptoms. So regarding the 5-year survival rate, it about 70% and as high as 95% in the absence of distant metastasis. With the renal vein invasion or extension into the perinephral fat, the 5-year survival rate reduced to approximately 60%. So in this chapter, we discuss mainly on the pathological aspect. Okay, so thank you very much.